Our mission, for those of you who aren't familiar, is to transform healthcare through technology and innovation by convening experts and executives like you have here today. And this is a great example of what eHealth Initiative and Foundation does, is these really impressive, influential experts together to talk about these issues that are so important to folks out in the field. Next slide. If you're not a part of the eHealth Initiative right now, this is just a sampling of some of the different organizations that we bring together to discuss these issues, come up with recommendations, speak on our webinars, share information. You need to have your company's name listed there. So feel free to chat with me, Claudia, or anybody online here today. We will get back to you after the session today and tell you how you can get engaged with the organization. We are a very large organization, and we work with over 20,000 different executives through our different activities and programs, and would love to have you engage with us. Our areas of focus are listed here: transparency, interoperability, privacy, and analytics. Really pertinent topics right now, and we're figuring out how all of these topics right now kind of intersect and interact with COVID-19. So we have launched last 12 weeks, really, a set of COVID-19 webinars and series. If you go to the next slide there, Claudia. We've got a whole group that are already online, about 12 different sessions, at least, maybe 15, that are available on our website, ehidc.org, covering a whole host of topics related to COVID-19. And we have a number of topics coming up next week as well. We're going to be talking on June 1st about consumer behaviors and how they've changed since COVID-19 has arrived. We're going to be talking next week with Patrick James. I'm really excited about this interview as well, from Quest Diagnostics, all about testing and how testing is going to help us really get back to work and get back to school. So that should be an interesting conversation. And then on the 11th, we're going to be talking about what's next for healthcare after COVID-19. So really interesting topics. If you don't see a topic online there or coming up that you'd like us to discuss, shoot us an email, shoot Amy an email there at ehidc.org, and we'd love to get you involved and figure out what it is we're missing and we need to discuss. Next slide, Claudia. Okay, I do want to thank, we are a nonprofit. All of these programs and our educational programs just would really not be possible at all without the support of organizations like ProMedica, who we're going to hear from today. But you know, it's really difficult to run a small nonprofit in the middle of a pandemic, and we've been really fortunate to have a number of organizations like ProMedica and others who really stepped up and helped support these educational programs that I think are just so valuable to so many people in the industry. So I want to thank them sincerely for doing that. And I think we're going to hear from Gregg first, actually. So Gregg Church.
Thank you.
Turn it over to you.
Thanks, Jennifer.
Sure.
All right. Can you guys hear me? Okay, I want to make sure we do a sound check just
Perfect.
before I get started. Okay,
yep.
Awesome. First of all, and KPI Ninja, our partner, I want to thank them for being part of this as well. We've worked quickly, you know, as the pandemic started here in the States, to look at how do we create, you know, some better tracking and systems to help organizations of all types get to critical information. And before I get started, one of the challenges that we've seen, and I think many of you will appreciate on this call today, you know, as you know, ONC made some great strides back on March 18th with the final interoperability rule. There are still some challenges around that. One of the challenges we've seen in the COVID crisis is not everybody's getting the information timely, and laboratory results obviously are critical. And we've seen, unfortunately, some pushback where even HIEs and some of the other state networks, you know, who are really trying to manage the pandemic more efficiently and be proactive, are getting limited information. So we've seen that as a challenge. Not to criticize by any means what's going on, because I think we're all working together as quick as we can, you know, to solve a use case and some of these challenges that we just never been presented with before. The other challenge we have is now we want to get to this data and we want to get to it real time through interoperability. And Ben's here to kind of talk about some of the challenges around patient matching. We as a vendor in that space really are hearing how critical it is if you don't have good information and you don't get complete information on the patients, even during testing and the upfront process of collecting that information, whether it's through a phone bank or a web form, as testing sites have had to come up quickly in the areas and communities around the country, it's very hard then to be able to quickly notify individuals of their test results and make sure we get them into care faster. So we've been asked as a company and as a vendor, how do we enrich that, process and be able to verify and be able to collect better information? So I'm going to walk through a couple of things I think that are important. And then as the other, speakers get into their parts, I think you'll see there's a nice tie-in together. So who's going to advance the slides? Are we doing it ourselves or? There we go. Perfect. So these are builds. Go ahead and build them, whoever's running the slides. So somebody asked in some of the registration questions, how big of a problem is patient matching and is it really widespread? Well, according to sources out there that are tracking this information, every year in America, wrong patient events that result in death or harm each year is around 9% of the time. Health providers, unfortunately, because they're so busy and there's so much going on in their care requirements, they end up creating duplicate patients about 8% of the time. But more staggering is the industry average across America. If you look at health systems, laboratories, provider offices, we're still seeing double-digit duplication rates, anywhere from 10 to 20%. And when we look at that, it starts to concern us, how are we going to properly care for patients, notify patients, share information if we're still questioning whether or not we've got the right patient and the right information? So the next build there. So is it a problem in America? Yes. Are we doing something about it? Yeah, there are a lot of great initiatives going on at the national level. ONC obviously taking a stance, working with Congress on how do we accelerate, how do we get to a universal patient ID, how do we make that interoperability, more sustainable and reliable. Next build real quick. So what's happening, patient misidentification is costly and deadly, and we don't want to hear the word deadly, especially during a pandemic crisis like COVID. We want to be able to get to that unique identification quickly as we're passing information between the health systems, between HIEs, the laboratories, anybody that needs that access information, especially when Vineeth starts talking about analytics, they're going to rely heavily on good information. And I think there's one more build on the slide. And a number that John Hopkins, has recently published that preventable medical errors right now are the third leading cause of death in the United States, around 440,000 deaths per year. And anytime you see a number like that, you start to question, what can we be doing together? And there are a lot of great vendors in this space and, working together, trying to figure out how to harmonize the data, normalize it, share it accurately, I think is really what we're trying to do. As contact tracing really is going to become such a key thing right now that people are looking at as far as bringing employees back into the workplace safely, bringing patients back into healthcare safely, whether it's, for testing at the lab, whether it's clinical care in the provider office and, and surgeries. So next slide. So I want to kind of set the stage. So why do we still have patient duplicates? There really is no industry standard for registration. There's discussion right now happening around that topic. There are lots of different systems out there, a lot of siloed systems. People register, collect information differently. The lack of a universal patient ID obviously has been the topic. Data quality, what are the standards for data quality? How do we ensure we have enough data attributes from each registration source? So at the point of care, making sure that we collect enough information. And there really is no single MPI or referential matching service out there individually that can actually solve this problem. So there are a lot of different systems that are coming up, to work in concert with each other and harmonization of the data. So who's really at fault? And we talk about this a lot. Go ahead, next slide. All healthcare organizations, whether you're at the point of care in the doctor's office, you're in the laboratory, you're in the hospital registration area, we need to really focus on having better registration standards at the point of care. We need to make sure there's more accountability for ongoing data quality standards. We talk about that a lot with our customers and ensuring that they have those processes in place. And some of the conventional MPIs really were not designed for real-time transaction processing. And real-time interoperability is a challenge when you want to get information, from a provider to the ER, from the ER back in, to a different care coordination setting. So that's challenging, as you're passing that data. And then the people that are actually responsible to manage the data quality of the data stewards, really helping them be better trained and be better positioned to look for inefficiencies, and where technology can't do the perfect match, how do you get them in there to really understand and correct those issues? And I think better data management protocols and processes across the industry would really be helpful. So that's kind of setting the stage. Go ahead and next slide. We want to take now, the stance of how do we work together? How do we take technology? How do we take good information, combine it together, but make it more actionable? And, Harvey, I think Ben, I'm sorry, Ben's going to talk a little bit about some of the initiatives that I think are going to help us, as we forge forward in this.
Great. Thanks very much, Greg, for that intro. And thanks very much for Jennifer and Claudia for organizing this, and Jennifer for moderating. We really appreciate that, and the EHI team work on this effort. For those that don't know, Pew, we're a large research and public policy nonprofit. We've been doing about 3 years or so years worth of work on patient identification and matching. And as Greg mentioned, this patient identification and matching challenge isn't anything that's new to healthcare. We've been struggling with it for decades. And even though the opportunity for unique identifier came up earlier, we're not going to have one in the near term, even if there was a legislative prohibition lifted today. While a unique identifier would certainly be helpful, there are opportunities to make progress in the near term, and that's what I'll be focused on. Next slide, please. So when we typically talk about matching and identity, we often talk about in the construct of healthcare, right? How can you pull up the right record when a patient walks in the door? Or how can one healthcare organization share that information effectively with another? That same issue is now cropping up when we talk about contact tracing and ensuring that different healthcare organizations, for example, labs or hospitals, share the relevant demographic data with public health authorities to begin the contact tracing. So we know from data published a few years ago that often some of this critical demographic data simply isn't being sent. So in this one study, addresses were available 90% of the time by public health authorities in Wisconsin, only about half the time in Indiana. Same thing with phone number. In Indiana, phone number was being sent from labs to public health a little less than half the time and around a third of the time in Wisconsin. And even when phone number was sent, according to this study, it was the phone number of the healthcare provider and not the patient. So public health authorities in that case, when they're trying to begin this contact tracing process and to reach out to that individual, they really don't have the information they need to be doing it. And in the interim, while they're looking for it, either contacting the healthcare provider, sometimes using other advanced tools to get the data, they could be wasting days. All the while, the virus could be spreading more and more and putting more patients at risk. One of the challenges here is that sometimes labs aren't getting this information in the first place. And so how can a lab be sending information that they're not getting from a healthcare provider? And so there's a lot of gaps to the sharing of the critical contact and demographic data from the point of capture all the way through the lab into public health that need to be addressed. The second challenge with patient matching is challenges with standardization. We did a research project with the Reagan Street Institute where we looked at whether if everyone formats data in the same way, whether that would improve match rates. We looked at formatting last name, telephone number, addresses, and so forth. And we had the folks at Reagan Street used 4 databases where they ran a matching algorithm, standardized all the data, and then reran the algorithm to see what happens. And what they found was that standardizing some things like date of birth isn't that helpful for better matching of records. However, standardizing address is helpful. Specifically, standardizing address to the format used by the US Postal Service. We all use that standard pretty much every day when you go online and go buy something from a website. Oftentimes your address will be slightly reformatted and they'll say, did you mean this? And maybe there'll be capitalization or other slight changes. That's often using the US Postal Service format. The pickle is that use of that format and a free service that the Postal Service offers to convert addresses into that format isn't available for healthcare. The USPS offers a free tool to convert addresses for shipping purposes, not for healthcare. And so there really is an opportunity to open up that service and allow healthcare to be using it. Next slide, please. And if you can build the slides, it'd be great. Thank you. So how can ONC help? So first, it's important to know that if you go back and look at ONC's mission, so ONC was created in the HITECH Act and the Recovery Act 2009, and one element of their mission is to really focus on infectious disease outbreaks and improve the data exchange that'll facilitate a response. And as we're seeing with this current pandemic, the inability to effectively exchange patient demographic information and to disambiguate identities is one of the key challenges that we're being faced today, especially on one of the key pillars to reopening the country, which is contact tracing. So ONC can really help in a couple ways. One is as part of rulemaking earlier this year, ONC listed key patient demographic data, and that's over there on the right. EHRs are going to have to make some of this information available, or make all this information available via standard APIs. And they've added new data that previously wasn't made available, such as email address. This list of demographic data is a roadmap that all healthcare organizations, EHRs and others, can be using to share data, to understand who somebody is, and then contact them for contact tracing as needed. And the second is that ONC can work with USPS to open up that address standardization API so that healthcare can be using it and further reap the benefits of those data standards. Next slide, please. And this is just going to be my contact information. Happy to answer questions. Follow me on Twitter. Sometimes I say something mildly entertaining. Thanks.
And Ben, I just want to confirm, you said you're talking United States Postal Service, right?
Yeah, sorry about not clarifying. The U.S. Postal Service, so they play a critical role in helping improve this patient matching challenge.
Okay, great. We're getting a lot of questions about acronyms, guys, so I just want to make sure everyone knows what we're talking about. Thanks. Okay.
Good afternoon,
Harvey.
everyone.
Yeah.
My name is Harvey Guindi. I'm the CIO with HNL Lab Medicine, also known as Health Network Laboratories. So before we begin and get into some of the detail of our topic, I figured I'd just share with you a little bit of who we are and the space that we're in. Next slide. So our mission is simple. The most actionable piece of information in our health records is diagnostic lab data that comes out. It makes up the majority of patient health records, and it's certainly one of the things that drives most of care, from diagnosis to prognosis to treatment plans. So we recognize that as being an important part of what we do. A lot of times we are in the background, but certainly the COVID-19 situation has really put diagnostic lab testing on the map and made many people more aware of the kind of work that we do in the background. Next slide. So just by way of introducing HNL and just making it a little bit more transparent, we're a regional diagnostic testing provider in the Pennsylvania market near Philly. We have about 1,100 plus employees. We see on an annual basis about 3 million patients. We report out about 60 million results. Our call center is very busy. I think that number is probably higher, probably closer to 1 million calls a year that they handle. We serve about 30 different hospitals. We run 12 different labs. We provide a bunch of novel services from blood banking to forensic pathology, anatomic pathology, genetic testing, etc. And we provide a lot of concierge services that have really transformed the space where a patient has really become more of a consumer. So that's just a little bit about HNL and the space that we're in. Next slide. Our geographic footprint, like I said, is primarily Eastern Pennsylvania, New Jersey. We do have clients in several states along the East Coast. So we've got some exposure and variance as far as reporting jurisdictions and what they're asking for and the variables that come with them. When it comes to patient matching, certainly as Gregg and Ben have put it, if we don't get the information correctly, it's very hard for us to report it out correctly. And certainly since we're in the middle, receiving that electronically is the most surefire way of ensuring that we've got completion as well as reducing variability. Not long ago, we did an investigation as far as our patient records as we've implemented an EMPI solution based on a subset of data to kind of give us an idea of where the problem is. We saw that from an absolute duplicate perspective, about 7.5% of patient records we have were absolute duplicates. There was no question that these were exactly the same. And then another 23 or so percent with a 90% confidence, these were likely the same persons, just small variations in them. And the reason why this happens, especially in our space, is that we're providing services for a variety of providers, from nursing homes, skilled care facilities, rehab centers, jails, hospitals, physicians' offices, and certainly the criteria and the method of delivering patient demographics to us in an electronic fashion or in a paper fashion can vary quite a bit. And so we've put a lot of effort into trying to fix this. Now, for us, it was always around following the money, and it was always a post process matching and identification. And as Gregg has put it, it really needs to be on the front end, or more transactional based. So that's just a little bit of the intro that I wanted to offer before we get into the Q&A part.
Great, thank you. Vineeth?
Hi, this is Vineeth Yeddula. I'm the co-founder and CEO at KPI Ninja. So thanks to Claudia, Jennifer, and eHealth Initiative for this opportunity to share some of the work we're doing around COVID-19 with this group. So first of all, I would like to take this opportunity to share our thoughts and prayers with all those who have been impacted with COVID-19, and especially those who have lost loved ones. We recognize that these are unprecedented times with the global spread of COVID-19, yet we also see the reason for optimism and hope for the future. Next slide. So COVID-19 has shined a light on the need to have a really robust technology and data management infrastructure to get real-time insights, as well as to better manage the limited resources that are available. The resources could be, ICU beds, ventilators, or, the lab test completed, and so on. So it's really important, that the data and technology is going to be playing a key role as we live in this new phase of our lives. And what we are seeing is, from a technology and data management standpoint around COVID-19, we are seeing three major categories in here. Real-time COVID-19 insights, digital contact tracing, and in the future around immunization and vaccination. So I'll be focusing on the first two bodies of work here. And if you go to the, if you expand the slide, perfect. So what we are seeing is during the early phases of COVID-19, around March, April timeframes, so we have seen public health organizations, local, states, as well as national organizations focus heavily around interoperability and
building real-time insights around lab testing, bed management, identifying and managing high-risk populations, tracking PPEs, ventilators, and so on, and also even measuring social distancing efforts. HIEs, the health information exchanges, who already have this infrastructure from an interoperability standpoint in several regions and states, have played an integral role in supporting and accelerating these efforts. Over the last 6 to 8 weeks, we have seen several counties and states, focus heavily around contact tracing efforts. And while the concept of contact tracing is not new to public health, the scale at which we are doing has created an emphasis on the need to have digital contact tracing tools to expand the reach as well as the efficacy of the contact tracers itself. So apart from building the workforce, which has been the core focus from a public health standpoint, we also seeing public health focus quite a bit around digital contact tracing efforts like case management solutions and proximity tracking, self-assessment tools around COVID-19 to reduce the burden of data collection and also increase the efficiency itself. If you go to the next slide. So this shows quick, visualizations around real-time COVID-19 insights. So the top left graph is just a quick snapshot of, taking, data on top of a health information exchange and profiling, the COVID-19 patients, understanding, the characteristics of these patients, identifying, which patients are hospitalized and what are the underlying conditions that these patients have and so on. And to the right on the top is just a quick snapshot on measuring social distancing effectiveness. This is data coming in from public-private data sets and where we can track information around at a county level. And the bottom two, visualizations are real-time bed management and labs solutions. Again, just providing some quick snapshots on having this sort of like infrastructure on top of public health solutions like health information exchanges. How that could be leveraged and support the efforts around COVID-19. Next slide, please. So from a digital contact tracing tool standpoint, so we're seeing quite a bit of tech and data play to support public health in creating efficiencies, reducing the overall burden, and improving the data accuracy. So as an example, the screenshot to the left automatically brings in all the key information at a patient level for COVID-19 patients, right from the demographics, chronic conditions that the patients have, medications, and whether the patients are currently hospitalized or when the last lab test has been completed. All of this information, is brought into one picture, centralized around a patient. Having all of this information to provide it back to the public health, equips, the public health teams to be nimble in supporting the contact tracing efforts. And there are other tools, several other tools that are being used by public health, like digital case management solutions and proximity tracking. And as many of you may have heard about Apple and Google around creating this low Bluetooth exchange solution from an API integration standpoint, where you can anonymously identify hotspots and prioritize decontamination zones and stuff. So there are a lot of data and tech play around contact tracing efforts. Next slide, please. So this is my contact information, and if you'd like to learn more, please feel free to contact me. And I'll turn it over to Jennifer in regards to Q&A.
Great, excellent. All right, well, that was a really nice introduction from everybody. Thank you. So we've already got a bunch of questions coming in, but we do have kind of a simple question. So in terms of contact tracing for just myself, kind of the lay person, could somebody kind of walk me through exactly what happened? So someone's diagnosed with COVID-19 at the lab. I'm assuming, Harvey, that's something your organization would find the positive. Does it immediately go to the contact tracer then, to Vineeth, or maybe could you walk us through that a little bit?
I can walk you through a little bit at a high level. So contact tracing, as was mentioned before, is not novel or unique. It's actually been going on for a while within the healthcare. And there's certainly a lot of communicable diseases that have been, come before COVID. So from a lab perspective, once an identified patient tests positive for one of these communicable diseases at the state level and at the federal level, there is a reporting that happens. And for us, we do it electronically, the National Electronic Disease Surveillance System, and there's different state versions of that. We've got interfaces to them, and that information is sent immediately. From there, depending on the local government, the regional, the contact tracing could take place. So, for us, the most important thing is to ensure that we're delivering that information quickly and timely, and doing it electronically. Many years ago, this was manual and not in real time, and now it very much is in real time.
Yeah. So, and I think it also really depends on where you are. So states do this differently. So I'm in the state of Maryland, so we have state contact tracers, but my county also has contact tracers. So it really varies from where you are in the country. And I guess this has been one of the issues. Vineeth, maybe you could talk a little bit about, one of the problems has really been, how do you scale this and how do you do it consistently? And it sounds like you've got some really great technology tools there to help do this, but maybe could you address that a little bit?
Yeah, totally, Jennifer. So as contact tracing, at the scale that we are doing, it's really laborious efforts, on doing the contact tracing at such a huge scale. So once, a patient turns positive for COVID-19, so at a local, at a county level, or at the state level, so you get this information in real time. And the goal of contact tracing is to, get in touch with the patient who has been COVID positive, identify, all the, contacts that the patient has had recently, who might be exposed in order to stop the chain of transmission, right? So if you look at the whole process, the contact tracers are wanting to or needing to have the information around, the contact information for the patient and whether the patient is, hospitalized or not, and what's happening with the patient and all of their demographic information, right? So having all of this information at a place where they can easily access is step one. So a lot of the states and regions have health information exchanges and, where they can leverage the HIEs to get this information automated, where they can increase the accuracy of this information. And that would assist in, increasing and being more agile from a standpoint of outreaching to the patient. And the next step is, once you call the patient and try to get all of the information around their contacts and who might be exposed potentially. So that is where digitization has a play, where, if the county health departments or states, if they're using Excel or if they're using, they're documenting it manually. So you can potentially automate using technology where you can document a lot of this information using digital contact tracing tools, which could have automated workflows, where, for example, in the span of 14 days where the patient is quarantined, these tools and technologies can automatically send notifications, to the patients to input some, core parameters to assess the patient, and that could trigger and triage the patients where you need to be focusing. That would create a lot of efficiencies, as you could imagine, from a contact tracing perspective. So, so there's a lot of, play around digitizing the contact tracing at this, effort that we are undertaking to increase the efficiencies as well as increasing the accuracy of, identifying the right patients and increasing the outreach efforts.
Right. So, I mean, I guess the issue is it's not just, there's all these different sources of data. And first of all, you have to make sure those sources are right. And what if you have more than one Ben Moscovitch or more than one Jen Kovich? So how do you make sure they're correct? But even before we get to that point, Greg, one of the things is, you know, how do you even get vendors and providers? And certainly it's required that you report the COVID-19 test results. So the state has a list of everybody who's tested positive. But how do you get the information and the data shared from other organizations in order to get in touch with the other people and all of that? How does that work? How are people sharing?
Yeah, good question. I mean, it's been one of the challenges that we've seen, you know, as we've, you know, been working on different programs, working with KPI Ninja on more of a lab hub analytics platform in the last couple of months. Getting the laboratory data from all sources has definitely been a challenge. And I've reached out to Ben, I've reached out to others, you know, to see, you know, what we can do, you know, to collaborate and to aggregate and get the data. But not everybody has been willing to participate. And so there's been some gaps, you know, in getting the full picture. So a challenge. I'd love to hear from people on this call, you know, as well. You know, if you've got suggestions that can help all of us, it definitely has been a huge challenge in the last couple of months.
Ben, have you seen that in any of your data about, you know, difficulty getting data from labs and state registries, or?
Yeah, we've heard, we haven't seen hard data on this. We have kind of heard different suggestions from different folks. So in some cases, it's, you know, business practices where there's no incentive to be sharing the information. So why would you? In other cases, it might be issues with the feeds, where the feeds aren't capable of sending this information or configured in a way to send this information. In other cases, it could be concerns about privacy. You know, we've heard about increasing efforts to expand the types of data that need to be shared, including from state and local governments indicating that the information should be shared to address some of those challenges. But in addition to kind of traditional healthcare, there's also the other elements that are going to be conducting testing that are going to be really important that may be created de novo. For example, if we have pop-up testing sites, how are we going to be getting that information into public health with the relevant data that they need to conduct the contact tracing?
Interesting. So it's not like this is all coming from a formal hospital EHR system. You've got all kinds of systems that are testing. So what's, I guess, kind of one of your biggest concerns about the contact tracing in terms of the accuracy of the data? I mean, where do you think the gaps are in terms of the accuracy? Greg, you have any comments?
Yeah, I mean, without naming, you know, situations, you know, but a couple of use cases we've heard is you've got, you know, a variety of health systems that are doing testing. You've got, you know, laboratories obviously involved, and you've got this urgency of how quickly you can, you know, get people in, get them tested, get the results out. What we've seen is because the uncertainty of the data and missing attributes that are critical, when you have very similar naming structures, your name is a little bit easier, right? There's probably less of you to match on, but you get into the common names and you get into communities where there's a lot of similar last names, then it becomes a huge issue, because if you make a bad judgment call and you start contacting people incorrectly and they're not positive for COVID, you've now created a whole different set of issues, right? So we're looking carefully and quickly as we're talking to the sources of data that are coming in. Do we have enough data attributes to match on it? If we don't, let's go solve that problem and do it quickly. Because that is one way to do it. It doesn't mean you have to start over with your MPI or start over with technology. It may just be quickly enhancing data that's missing in those data sets. Because once you do that, and Ben made a good point earlier with the USPS, United States Postal Service, address normalization, that's another great way not only to match, but to verify. You know, when you have enough attributes, when I say enough, just so everyone knows, first name, last name, date of birth, phone number, minimum, you know, mailing address, right? Those, you can get by without gender, you can get by without some of the other, you know, secondary attributes, but if you don't have enough of the core, then you're making really bad decisions and you're guessing. And this cannot be a guessing game, especially when you're talking about contact tracing and notifying people quickly and reliably.
I mean, it sounds like there's, you know, the risk that there could also be duplicative effort. So if you've got, you know,
Sure.
all these states and counties and public health departments, you know, how do you know who's tracking who? I mean, is there an argument here for some kind of centralized contact tracing for public health? Or is the, you know, are we already set up as kind of a decentralized democratic system here? I don't know, Ben, if you could maybe comment on that. I mean, because I think it,
might be good for,
it touches a little bit on the universal identifier issues, or the unique identifiers.
Yeah, I can't speak to whether we should have kind of
Right.
a single entity in charge of contact tracing,
Right.
but the system we have today is where state and local governments are really taking the lead, and public health authorities in state and local governments are taking the lead on this. And so how can we empower them with the data they need to do this effectively? You know, there's been some estimates that we have just a few thousand contact tracers today, or we did at the start of all this. And that estimates range that we needed somewhere between maybe 100 to 300,000 contact tracers. And there's been efforts by Johns Hopkins to train more contact tracers. But regardless, we don't have as many today as we likely need going forward. And so how can we make the best use of the time of the contact tracers and the resources we have? And one way to do that is to ensure that they immediately get the information they need and not use up some of their time and resources trying to find that phone number so that they can begin the contact process.
Yeah, great point. Great point. Vineeth, any data or sense of how long it takes to do contact tracing and how kind of electronic solutions can help with that or make it more efficient?
Yeah, so from a data standpoint, we are conducting studies on how technology and the availability of real-time data could impact from an efficiency standpoint on the contact tracing workforce itself. So those studies are happening as we speak. However, we are seeing you know, from at least, you know, from several different implementations and stuff. So we are seeing quite a bit of efficiency increase by automating a lot of this information and having this readily available to the contact tracers itself. And also there are some other challenges, you know, not only having a digitized solution is necessary, but also keeping in mind around the different languages that are being spoken in some communities and making sure that, you know, there is the technology does allow those kinds of aspects because at the end of the day, if you're trying to automate, you know, contacting some of these, contacting, you know, the COVID-19 positive patients over the next 14 days and trying to seek information digitally. So you want to make sure that you're communicating based upon the different language needs and different parameters that might be existing as well. So to summarize, you know, some of the studies are happening as we speak, and you know, but we definitely see a huge play that technology and data management is going to be playing in regards to contact tracing as we roll out hundreds and thousands of contact tracers eventually.
Yeah. So I think a lot of people on the phone probably are aware we don't have a universal identifier. So there isn't one number for every person in the country. So Gregg, on a national level, how do you trust the data and kind of make sure you don't have duplicative efforts everywhere if you don't have a universal, you know, how do you know one person is one person?
Yeah, that's a challenge because there's no common registry, you know, to bounce off against for an MPI. So there's a lot of duplicate effort. And unfortunately, the data sits out in so many different databases and silos. It's difficult. I know there are initiatives, you know, where we're creating more interoperability roadmaps, you know, and you've got organizations like Chic and others doing patient-centered data home. Even those, you know, it's relying on the data coming in, how accurate it is before the data goes back out, you know, and that's one of our challenges, you know, and whether you have a universal ID or not, it's how we're going to manage it, how people are going to access it, and still validate whether this is really a unique identity using that ID. So, I mean, people have heard around biometrics maybe being a possibility, to use to add another level of validation. And I think a question came up about how can you help track the homeless population where they don't have identification, they don't have an ID or ways to really validate back who they are. Maybe biometrics in that case could help, because as they're going from, an ER to a facility, that could be a way to validate. But again, you got to get everyone to agree on the standards of biometrics, right? Because there's different, ways to do biometrics and different levels of biometrics. So I don't have an easy answer for that, because it definitely is a challenge right now, but it's something that as more and more, as employers are going to try to bring people back safely, and, how do you track this all the way through? And you've got patients going in and out of different health systems and seeing different laboratories. It's now that we've got to figure out how to do a better match. I mean, now is the time really to really put our heads together on this.
Yeah.
Which I believe with ONC, the Office of the National Coordinator, on Monday, they've got a session coming up. If you haven't registered, it's really a working group to get mindset, to get people to work together on what do we do faster. We can't wait for an ID, and there are things that we need to do now today.
Right. Great point. A lot of unanswered questions. Harvey, I've got a question for you in terms of duplicative lab testing. So one of the attendees today wants to know, how significant is the issue of duplicate lab tests in terms of over-reporting? On the other side of that, and then on the flip side of that, are labs concerned maybe we're not sharing enough data for the purpose of matching?
No, that's a great question. The duplicity of patient data within the labs is pretty high. Like I mentioned, some of our analysis showed that it's, it could be 7% up to 23%, depending on the data sets. So it's really incumbent on the lab who is doing this reporting to try to implement some sort of solutions to make sure that you're deduplicating, that you're identifying and matching correctly. So one of the things that I wanted to highlight is there's a difference between identifying and matching. And we realized this a long time ago when we first started rolling out patient portals, maybe 6-7 years ago. It's one thing to identify a person, and you could use some of the credit databases where, they ask you certain questions that ultimately determine that it's really Harvey and not somebody else. But then once you know that, matching them to your record, if you've got 3 potential Harveys, is a different challenge. And so there's the potential for over-reporting, of course, exists, but it's not going to be, the tests are not going to be reported more than one time. You just might have different personalities in the EHR because you came in through different mechanisms and they haven't really consolidated, or they don't have any MPI solution in place. So that's, for us, it's a shift to collect more data. For a long time, the lab, based on CAP regulation, really required two IDs to label specimen right and to track them through a system, name and date of birth. And that's pretty much what they verify and ask every single time. Mm-hmm. And, the adding tasks to that process is important, but ultimately becomes a balance between privacy and data collection. And we've seen this all across the board. I'll give you one example. For a long time, we didn't require or ask for ID because we serve a population that some of them don't have IDs. And we started putting in some eligibility checking up front, and started asking and using the government issued IDs to do the lookup to verify that they're real. And we were surprised to see that there were several people who were presenting IDs of deceased individuals. Wow. So it's a tricky situation, and it's going to come down to the same thing again: balance between privacy and data collection for the benefit of population health.
And can you just clarify for folks what data elements labs actually get?
So in a typical EDT order that we get from an EMR like an Epic or something like that, and I'll use the example of more of an outpatient. We'll get the first name, sex, date of birth, and those things are usually the ones we absolutely require. The ordering entity may or may not provide us address information. It may or may not be in good shape. Up until a couple years ago, we didn't even bother collecting things like email or cell phone numbers for text messaging and stuff. As we've recognized, and part of what I mentioned in the beginning, we're making the shift and recognizing that we're in a consumer-driven space now, not purely healthcare, and we need to adopt more of these consumer kinds of practices. Somebody mentioned in the Q&A, recalls, product recalls, happen fairly consistently with good reach out, and it's not any different than what we're trying to do from a contact tracing perspective.
Yeah. Really interesting question here from someone. Does anyone know what China's using for contact tracing? Any of you? Interesting question. We're gonna have to figure that out. Gregg, can you share some insights on the difficulties you've encountered in getting people and households to understand kind of the urgency of the contact tracing call, which I assume is someone calling and saying, hey, give me a list of everybody you've spoken with. It takes some time. So any thoughts on that?
So more getting just people to respond and participate, is that the question?
Yeah, I guess. They haven't been specific here. Yeah.
Yeah, I mean, the urgency, I guess, would be understanding that they've had direct contact, whether it's employment or social, and, if they can reach them and reach them successfully, which I think is part of our discussion. And Harvey, I think that was great what you just said. Nobody really realized a few years ago, email address, how important that is, and cell phone numbers. Now we're starting to realize the one thing that is consistent with people, they keep their emails and they keep their cell phone numbers longer. A lot of transient people have different addresses. So getting them to take action and take the call and doing something about it, I hope people are responsible. Maybe others can comment on that as well. Vineeth, I don't know if you're, hearing any issues around that and what to offer suggestions there.
No, I think I don't have any other comments other than what you shared, Gregg. I mean, it's a really important, for to get hold of the patients who are COVID positive, and the first step is to get all the right information, the demographics information, the contact information, so that you can contact the the patient. And I think, if you look at, the patients who might be, or others who might be exposed, with the COVID-19 positive patient, right? It's typically, if they're working, it's their colleagues or, it's their family. So it is, really important, to keep, not only this patient, from a social distancing standpoint, safe, but also, get that contact information of their colleagues or, of their family members or friends, so that they can be contacted and, they could be, so that you can break the chain, right? So it's a really important, aspect of, getting hold of that, index patient. And then part of the training of getting hold of this patient, there has been a lot of training that is going on as part of the contact tracing, to get hold of this patient and to increase the outreach efforts and so on. So not a lot of other comments, but it's just really, really important body of work to get hold of that index patient.
I'll add one thing, and I think it was a question that we had seen earlier, concerns about family, household members, and how do you link people together? So you've got situations where people share, maybe a cell phone number, or they share, an email address in their record information. A lot of times what you can do when you're looking at family members where you might have a minor or your foster parent, address normalization and linking to the same household mailing address is powerful, because you can definitely group people together faster that way when you're missing key information on other family household attributes, you know, or individuals with their attributes missing. So keep that in mind as you're listening, that if you're able to, in your data management process, link family members together, you know, whether it's biological or legal guardian, address is really powerful in doing that. So something to remember.
Great point, great point. Ben, we've had a lot of questions on privacy and we're just about at the top of the hour, but I'm going to give you a minute to answer. Maybe you can just kind of round up some of the key concerns around contact tracing, you know, that you're hearing. And if you think that any of this is going to encourage the government to do something about it, just your perspective.
Sure. So I can't speak to privacy specifically. As was mentioned earlier, contact tracing isn't new to this pandemic. Public health authorities have been doing it for some time. What's different now is the scale at which it's likely needed. And when we talk about patient matching and patient identity generally, again, this is information that is often shared or captured at least. And now the question is, how can we use this information most effectively? So example, we're already sharing address information between healthcare providers. How can we best optimize the use of that information, use of address, so that it actually achieves the goal of care coordination for patients, and then supporting other uses, supporting other disambiguation of identity to improve care?
Well, we are at the top of the hour, and I want to thank everybody for joining us today. I think this has been a great group, and we certainly got through a lot today. Gregg Church, Vineeth, Harvey, Ben, thank you all for joining us today. Thanks for everybody at home for joining us today. We are going to have a session actually next week on privacy with Alice Leiter, our
good one.
So
yeah, that's a good one.
Folks, sign up for that, and then we'll see you back there. We'll have a whole hour to talk about that. And thank you again for Medica for supporting this. We're really delighted to have you guys here today. Such an important topic and lots more to discuss. So come on back. And
thank you. And I do want to echo one thing real quick that Vineeth said. I mean, thank you to everyone on this call, whether you're a vendor, you're a frontline healthcare provider, a health organization. It goes without saying, this is such a great country, and we do work together, and I love the collaboration that we're seeing out of this pandemic. So thank you to all that are on the call and all that hard work and effort you're putting into this. It's fantastic. Thank you, Jen.
Thank you. All right, everybody. Have a great afternoon. Stay healthy and safe.
Bye-bye.
Thank you.
Bye.
Bye.